This is the scout views, how we see the elbows being extended, the head is not visible, the craniocaudal scout view. And the images we gain are these ones. And beside the positioning, it's important that we choose the right algorithm, so the bone algorithm, the bone filter. This is a soft tissue filter where we almost see no detail of the bone itself. This one is much better, but besides the filter, it's important that we window our images, that we administer the grayscale to the perfect level where we can visualize all bony structures in detail. It's a very subtle lesion we have here, a very discrete radiolucent line, but this is also a fragmented conoid process. So we tried to score the image quality with performing examination in lateral recumbency and in sternal or ventral recumbency. And here we have the scout views, and you immediately see that the head and the neck are in between the elbows. When we do it in sternal or a dorsal recumbency, it doesn't matter. And the fact that the head is present will result in artifacts in our images. And these are the same elbow performed in the three positions. And if we look to this image, this one and this one, the dorsal positioning and the ventral positioning, they are much more stripes and streaks present in these images, causing artifacts. And certainly in subtle lesions, it might hinder your diagnosis. So this is the examination we did. So all images, the lateral ones, the ventral dorsal ones, were blinded. They were cut, as you see, and scored independently by several people. So what we could conclude is that the best image on transfers are the ones with the head outside of the gantry. This is having much more artifacts and blurring. And then besides that, regarding the thickness, 0.6 millimeter thickness with an overlap of 50%. These ones obtain the best images. The overlap we need to perform the MPR. The reconstructed images, if we perform the examinations with the overlap, your reconstructions will be very beautiful. So 0.6, which is very thin, 1 millimeter thickness is also still okay with an overlap of 50% as well. And here we have a case, an elbow patient, where there's not much to see. The elbows are really, or at least the bony structures nicely delineated, no arthrosis. We can discuss a little bit about the delineation of the medial conoid process, which we can't follow very well. And these are the images obtained in lateral recumbency and this one in sternal recumbency. The same elbow. Here we pick up the discrete lesions. And here we can see it as well, but not so well as in this image. And if we look to the reconstructed images, this is the one gained from the lateral recumbency. We see much better the radiolucent line in contrast to this sagittal image, meaning the non-displaced fragment. So about conoid pathology, some pathology can be present in cases, so it's not only displaced fragments, but we look to the shape of the conoid. This is a perfect normal elbow, the head of the radius and a normal delineation of the medial conoid process. This is not a fragment, it's a sesamoid bone at the lateral side of the head of the radius. So we don't pick it up in every animal, but now and then we do. We also look to the instance of osteophytes, as we see in this example. Density changes is not homogeneous, this area. We look if there's sclerosis present or not at the level of the trochlear notch. And this is again a very discrete lesion. A very fine, subtle, radiolucent line, meaning that it's a fissure we are dealing with. And then the non-displaced, as we just saw, and the displaced fragments. And here it's important often for the surgeon, when they are really displaced, how many fragments are present in the elbow joint. About the shape of the conoid, I also want to say that there is a difference in breeds. So a golden retriever has a different shape of an elbow in relation to a shepherd dog or breed. So it's or breed dog. It's important that this will be investigated in the future as well, the shapes of the coronoid as well, and here an example of different fragments. So another study which was interesting, of course, but the results are really disappointed, is a CT evaluation of the coronoid. It was published in 2009, and they came to the result with moderately sensitive result for CT in detecting fragments. So that's really not the same result as we gained from our study, which I just presented. Then sclerosis, that's an issue. On a radiograph, it's an issue. On a CT, we tried to standardize it on a CT. I will show it immediately. But a lot of publications are described about the evaluation of sclerosis. People tried to classify it, to standardize it, to evaluate it by different people, experienced people, and there was no correlation between those people. So it is really a subjective interpretation, the incidence of sclerosis. And also this study tried to evaluate sclerosis, and the relevance was that the inter-observer agreement was moderate to perfect, but in between the different, or the intra-observer was actually quite well, but the between the different observers, it was poor for grading sclerosis. So what we tried to do was try to standardize sclerosis on CT, and we did that in a whole group of patients and tried to objectively develop measurement methods. So these are the results we gained, and on the images below, we tried in different areas, also at the level of the humeral condyle, at the level of the notch, the base here, the level of the apex of the coronoid, tried to measure the density in healthy and in diseased elbows. This is an example of a diseased elbow. You can't visualize it very well, or very well, you can't very well. But what I want to say is that the sclerosis, the Hounsfield units, the density we measure on CT is higher in a diseased elbow in contrast to a normal elbow. So that are the results we gained. So an increase in Hounsfield units and also in bone mineral density. In specific regions, we could check and compare the results we gained in healthy versus diseased joints. The bone mineral density we measured because the phantom was included in all our CT studies, having a standardized density inside. So we used that phantom to check the bone mineral density. And also, if we look to the clinical relevance of the repeatability of the measurements, that was repeatable, the Hounsfield units and the density at the level of the coronoid base. So it's a real reliable method, and the region of interest may be used for clinical assessment of joints that are doubtful for having MCD, medial coronoid disease. So what still needs to be done is that this was a range of different breeds. Probably there is a difference in density. Also, I said about the shape of the coronary node, a difference in density between different breeds. So that's still something that needs to be investigated. But still, the preliminary results are there, that there's a difference in density at the level where we score sclerosis. Something about elbow arthrography. That's a technique where we administer contrast within the elbow joint itself, the same as we could do in arthrography on an X-ray. So, what is the aim of arthro-CT is that the cartilage is delineated by having the contrast in the joint space. So we don't see the cartilage itself, but we can visualize the delineation of the cartilage. And this is a study that had been published already. And here are our examples. This is a normal, healthy animal. We checked arthroscopically and radiographically and on CT whether the elbow was normal. We administered contrast, and on the sagittal MPR we see the delineation of the humeral condyle. We see the contrast filling the joint space, but between the subchondral bone and the contrast we see a hypodense line, and that's the delineation of the cartilage. The same at the level of the medial coronoid process itself. We see on top of the subchondral bone a dark line being delineated by the contrast. So intact cartilage in this case, and here we have a case where the cartilage is gone. We did it artificially to check if the method was working, and this is the arthro-CT we gained, the same plane as this one, and we see that the cartilage can be followed a little bit here and then we lose it. So the contrast is filling the defect we made in the cartilage. So arthro-CT, and we use it quite a lot in stifle joints, in tarsal joints as well, but also to evaluate cartilage in the elbow it might be useful, as we see here, where we have a Rottweiler quite aged already, with a lot of new bone formation. We see the osteophytes at different levels of our elbow joints and a huge displaced fragment. And the images of the arthro-CT, we see almost no joint space anymore, and we don't see any cartilage, no cartilage visible at the level of the humeral condyle and not at the level of the medial coronoid process. The same in the medial compartment, it looks collapsed almost. So there's no cartilage present anymore in this case. It's a case of a medial compartment syndrome, and it was confirmed on arthroscopy itself. You see there's no cartilage left on the humeral condyle and also no cartilage at the ulna, and this is the fragment that we pick up here. So something to end about arthroscopy. If we perform arthroscopy, it's a technique can be done quite easily in small animals. It's more small animals and small joints. It's more difficult. If we think about arthroscopy in human stifle or arthroscopy in a horse joint, they are very large joints. The problem in dogs is that joints are very, very small. Certainly the elbow joint. So arthroscopy can be helpful to diagnose elbow dysplasia, and there are first two steps in arthroscopy: the diagnostic arthroscopy, where we can visualize lesions we are dealing with, and we can check the medial coronoid process. Is it fractured? Is it normal? Yes or no? And beside that, we can perform surgical arthroscopy, where we don't only diagnose our lesion, but try to treat it. Like here, we see a forcing grasp, having or holding a displaced fragment here, and the fragment will be removed in a minimal invasive way. The problem is, in arthroscopy in small animals, is that you have to practice a lot, train a lot, that you have to be skilled. But I know from experience, if you follow a training, then you already are able to perform diagnostic arthroscopy. So if you know where you have to put your instruments, the diagnostic arthroscopy is not that difficult. But what about arthroscopy? What would we like to visualize? Of course, we would like to see bone. We would like to see cartilage, synovia, intra-articular ligaments, intra-articular tendons, and also soft tissues. So it's disappointing. If we look in ideal world, we could visualize all these structures. But also in all the imaging modalities we have available, it's not possible to evaluate all those structures together. So one study is more sensitive of one modality for soft tissues, like MR for instance, and other like CT and radiography are more sensitive to visualize bone. But in arthroscopy we are able to visualize cartilage, synovia, and intra-articular ligaments and intra-articular tendons. There are not so many present within the elbow joint, but still we can visualize that. The limitation of arthroscopy is that we can't visualize the subchondral bone. We only see the surface. So important if you start arthroscopy is that you know the approach, where you have to insert your instruments. And the first approach is always introduce a needle to insert fluid to make your joint distend. That's the first procedure we perform. And the second one is palpating the medial epicondyle and a little bit below and distally, 1/2 to 2 centimeter distally of the epicondyle is the joint space to introduce our scope. And then the instrument is a little bit more cranially, 0.8 millimeters, let's say, and a little bit more distally than the scope itself. So you see the joint space is very small. It needs to be at the exact places that you introduce your instruments. So what about lesions? Different lesions can be visualized, and all images here are a left elbow. We enter the elbow from the medial side. This is the medial humeral condyle, and a displaced fragment is nicely visible here. The surface of cartilage, and we see a part of the subchondral bone. Here we see a more discrete lesion. Let's say the cartilage is intact, more or less intact, not completely intact in this area, and this is a fragment we pick up. And here we only see the discrete fissure line in the cartilage. For the rest, the cartilage is intact, so we don't see anything of the subchondral bone. Here, 3 different cases. This one is severe. It's a right elbow. This is the medial side, quite intact, not completely intact of the medial humeral condyle. This one looks awful. It's the lateral humeral condyle. There's a defect, a hole in the lateral one, a large defect. This is synovial cell sarcoma. It's a tumor, a joint capsule tumor invading secondary the bony structures. Here we have a displaced fragment, huge fragment, and it caused a lot of lesions. These are piecing lesions, contact lesions. Cartilage is gone, and here also we see the subchondral bone. And this is an example where all the cartilage is gone. It's medial compartment syndrome. So what about incongruity and congruity? We haven't been talking about that. We can evaluate congruity and incongruity on a radiograph. Several studies are published about that. Also CT studies have been published. But also on arthroscopy we can evaluate it nicely. This is a complete congruent joint. As we see the medial ulna, at least the medial part, the coronoid process, and there's no level in between the head of the radius. We are able with arthroscopy to see some part of the lateral compartment of the elbow, not the whole lateral part, but if we move our scope, or not exactly move, because that's only also one of the limitations of arthroscopy in an elbow, we are not able to really move our scope in our joint. So we use oblique scopes with the surface of obliquity of 30 degrees, which helps us to see more of the joint by rotating the scope around its axis. And if we do that and we look to the lateral part, we see the lateral coronoid process, and we see there's a nice same level between the head of the radius and the lateral coronoid process. Here we have 2 cases of incongruity. The medial coronoid process, a small cartilage defect, and the radius in depth, and we already see that there's a difference in level between both, and also in the lateral compartment you see the step between ulna and radius. This case is an example with a fragment at the level of the medial coronoid process. So this part of the joint is visible here. And after removal of the fragment, it's very clear the step between the ulna and in the depth the radius. So it's really an incongruent joint after this fragment was removed. So something about the advantages, and in every technique there are limitations. We've seen that before. So the visualization of the intra-articular structures is really nice if we perform arthroscopy. It's minimal invasive, so there's a reduced post-operative pain and soft tissue damage. There's also a decreased patient morbidity and decreased hospitalization time. So also it's possible for the patient, they will have a quick recovery, and of course there is a need of rest a few weeks after a surgical procedure, but because arthroscopy is still surgery, is performed, so rest is always necessary, but the return to function is very fast. There is a reduced risk for infections, and which is really an advantage is that the different joints can be simultaneously be treated. We do that in elbow joints, in shoulder OCD joints as well, that both joints, bilateral joints, are treated within the same procedure. That's really an advantage. There's also less scarring, of course. We have just small holes that we can close with a stitch or clamp, so not really a cut in the skin and the soft tissues. Then periodic re-evaluation is possible, and what's interesting also for the owners is that you can store or capture the images of your procedure on a video or on a movie, or capture it and show it to the owner. So the disadvantages are of course expensive, but that's also the imaging modalities I showed. Nothing is cheap, everything is expensive, and in arthroscopy the instruments are very small, and the thickness is limited, diameter I mean, so fragile as well. Training is required. The arthroscope is difficult to manipulate, as I said already. We have really use or need the use of the obliquity of the front of the scope in order to rotate and enlarge our view. We can only see the surface, which can be a disadvantage. We don't see anything about the subhumeral bone. And of course you need to train yourself to be skilled, because also in the beginning the orientation is quite difficult. To know for sure that's cranial caudal, you can lose easily your orientation. What's also sometimes is a disadvantage is that you need a team. We perform arthroscopy always by two. One is holding the scope and one is holding the instrument. I know people are doing it themselves, just one person doing everything, but it's quite difficult to do so. Complications are rare. What might happen is that there's a leakage of fluids. Remember, you inserted fluids also in the beginning of arthroscopy to distend your elbow, but also during the procedure you use an irrigation of fluid constantly. And if you take out your instruments, bring them in and take out, you will have multiple holes in your soft tissues, and it might happen that fluid gets out and that your joint collapses and that you have to stop. So in order to avoid that, we use instrument cannulas. So we have one axis to the joint space, and we always use that one axis to introduce our instruments, and take them out, use another instrument, so to avoid multiple holes. Bleeding can occur, but also that's quite rare. So to conclude, we can say that radiography is reliable in evaluating medial coronoid disease. I said already, if you are skilled and trained in reading X-rays, radiography is doing well. Also, the evaluation of sclerosis can be tricky tricky on X-ray. The shape of the coronoid is redependent. I also mentioned that. And of course, in very young, immature dogs, the growth plates might hinder you to evaluate the coronoid process. So in general, 3 views, the ones we take, I know that here in Russia and also in Germany, routinely only 2 views are taken, but I think you need a lateral at least and a radiocaudal to evaluate the coronoid process and also to evaluate the medial condyle. In doubtful cases, CT is recommended. It is very useful in clinical patients, also in screening populations if there are doubtful cases, but also in CT it will provide much more information about the condition of the whole joint in relationship to radiography. And then CT and arthroscopy nearly have a perfect correlation. To end, I would like to advertise a little bit for those of you interested in CT. We have a joint venture with the DVG, the German association, and we organize CT user meetings all together. We organize them in Germany, and once every 3 years we organize it in Belgium. It will be the next one in 2020. It will be in the English language, and it's not only CT, the subject of the next meeting, it will be a comparative meeting where CT and MR will be compared in different pathologies in different anatomical regions. There also will be a session for nurses, for horse people, equine session, and small animals. And if you are interested to maybe send your cases for a second opinion, we are performing teleradiology to view your cases and write reports. Thank you for your attention.
Спасибо. Может быть, есть какие-то вопросы?
Спасибо большое за доклад. Единственное, можно уточнить, все-таки более показательно КТ в грудном или в боковом положении на медиальном единичном? На непревращении. Не могли бы вы уточнить, более показательно на непревращении медиального единичного отростка КТ проводить в грудном положении или в боковом положении?
So I think I showed it. We do it routinely in the lateral recumbency. We are used to that, but I think important is to keep the head outside the gantry. So the gantry is where the X-ray beam rotates. I know colleagues who position the dogs in thoracic position, but also these colleagues pull the head back. So maybe you can be afraid of that because of anesthesia and the tube that might flex, but if we keep attention to the anesthesiology, there are usually no problems with that. So it's really well possible, but that's important. The more tissue you have in the gantry, and we are talking then the neck and the elbows, the more artifacts will arise in your images. So whether you position the dog in the lateral or in the thoracic, keep the head outside the gantry. That's really important. And besides that, it's also important that you keep the elbows close together. So also in thoracic position, they will be extended. Keep them close together, that you can make your field of view smaller, and also that will increase the quality of your images. So that are the main things that are important to obtain good quality images, and that is also the positioning we will advise by the rules of the International Elbow Working Group. So as I said, we are making a standardized protocol about the settings, the thickness, but also the positioning of the images, the algorithm, and or positioning of the dog, and it's really important to keep the head out of the entry. Is that okay?
Thank you.
Пожалуйста, вопросы еще? Тогда у меня вопрос. По практической части существует такая проблема, это поиск инструментов при ортоскопии. То есть мы вводим оптическую трубку и дальше занимаемся тем, что мы ищем манипулятор. Это не всегда просто. Может быть, есть какие-то секреты? Как быстро найти инструмент?
About the instruments we use in arthroscopy, so it's important that we use very thin instruments, so the diameter of the scope we use in an elbow is a 1.8 millimeter and a 1.4, 2.4, I'm sorry, it's my colleague. I'm not performing arthroscopy myself anymore, I used to do it. So a 2.4 is really workable in the elbow joint. That's important. The short scopes we use in the elbow, in contrast to the shoulder, we use the long shaft scope because there is much more musculature than in the elbow. So that's important, and also regarding the lens in front. It's not a 0 degree scope. If it's really straight, flattened, then you cannot increase your view angle. So by having an angled scope of 25 or 30 degrees, we can rotate the scope around its axis, and then we are able to increase our field of visibility in the joint. Because we are limited really to move the scope itself. In contrast, in the shoulder, there we can really move the scope more than in the elbow joint. So it's important to have the obliquity in the lens. Then the instruments also,